an FDA approved procedure in the United States. That's one of the things that's really been a big change for us, is that we were kind of the last step, so to speak, and now we've had to convince the doctors that we work with that we need to be an early step.
Yeah, I agree. I mean, we absolutely need to try to find this condition early, and I think that it is an education process where we have to make sure that providers understand that we need to screen and check for this condition early and treat it, and now that we have this option. I think that with the insurance coverage and it becoming more available, that's also something that's not necessarily known by other eye care professionals. And the other issue is the screening tools. I think that not all eye care providers have topography and tomography, and so we need these really sensitive tests to evaluate and monitor for progression.
What we're approved for is progressive keratoconus, but the FDA didn't really define that. So how do you define it?
You know, that's a tricky question, because in some cases you could consider having keratoconus progression, because nobody is born with a cone-shaped cornea. But it's more and more important now to make this diagnosis, try and see if it's progressive, and you want to do it before that cornea reaches a certain pachymetry, because 400 is about the thickness that you can and cannot crosslink, at least what was set forward in the FDA protocol. So anything that I can do in the office to show that that patient is progressing. And really this is more important, I think, when we're talking about documenting progression to be on label and to allow insurance to say, yes, I agree, we're going to reimburse for this procedure. So I will go very deep into the patient's history. What were your glasses last year? How fast is your vision changing? And I think even if someone says, boy, I've changed my glasses 4 times this year, that's probably enough to say this is clearly progressing because your prescription is progressing. We're also using a lot more sensitive diagnostics, tomography, topography, to look at the posterior cornea, look at the pachymetry, look at what's called the posterior float, which may be an earlier sign for progressing cornea ectasia after refractive surgery and keratoconus. Honestly, anything that I can do that shows it's worse now than it was 6 months ago or a year ago is enough for me to document progressive keratoconus.
We need to counsel the patient what the outcome to expect is. Are we curing keratoconus, or what are we doing?
Earlier is better. I tell all of our patients, the best I can do right now is keep you where you are. This treatment is to stabilize the cornea, to prevent progression, so you won't need X, Y, and Z procedures down the road.
So they're probably going to go back to wearing glasses if they were a glasses wearer, or going back to wearing contacts if they're a contact wearer. And you're also likely counseling them that they're going to go back to the provider that sent them to you, right, for long-term care.
Exactly. I tell them this is a team approach. We will do our best to stop this process from worsening. You're still going to have to go back to get your glasses, your contact lenses, although that prescription may change. So it's best to do the treatment now, let you heal, and then get back for the refractive procedure.
Brandon, I think one of the most common questions that our colleagues ask is, what's the pre-op corneal thickness that's required in order for a patient to be cross-linked? And then a follow-up question to that that's related is, during the treatment, because Photrexa viscous does cause some thinning of the stroma, and the requirement is to be at 400 microns, describe your process for implementing Photrexa to get to that level.
Sure, so you want that cornea to be 400 microns, especially before you turn that light on. And if you look back at the trials for cross-linking, you saw about 65 microns on average of thinning during the procedure with the Photrexa viscous. Now, we try a couple tricks to see if we can minimize some of that thinning during the procedure. So I traditionally do an epithelium off procedure, the approved protocol, and I like to put a lid speculum in while I'm making the epithelial defect. But then once we start the soak procedure, I'll often take that lid speculum out because patients really don't like it. And that way we can also keep the eye closed between the drops. Now we were getting a little less evaporative effect, try and minimize that thinning. But many times, especially if your patient is starting close to the 400 mark, it will actually, you'll see some decrease in your pachymetry. And about 10 minutes or so prior to the planned start of the irradiation, we'll check epichimetry. And if it's less than 400, we will switch over to the isotonic Photrexa. And you can see anywhere between 50 and I'd say 75 microns of thickening just by adding that isotonic Photrexa. As of yet, we've never had a cornea that we couldn't get to the start point of 400 microns before turning on the light.
So maybe we can chat a little bit about helping our colleagues who are just getting started in cross-linking. Any pearls around the time of surgery or in the postoperative period and understanding the healing process?
Well, to me at least, the critical issue is to get the epithelium to heal again. And you're not really safe or out of the woods until you get the cornea to re-epithelialize. And so that's really the challenge. We want it to re-epithelialize as rapidly as possible. So that's usually for us lubricants, bandaged contact lens, and careful follow-up.
I think people do sometimes ask about haze. Other physicians have questions, and I think it's normal to see postoperative haze as normal and expected after cross-linking. I think that what we don't want is for the haze to be significant and affect visual acuity, but typically it doesn't. It does. Haze is a normal healing response of the cornea, and I think that we do expect to see some, and it does fade with time. I think also we have to address the eye rubbers. We have to make sure that I'm suggesting antihistamine therapy, as well as talking to patients about their habits. I mean, many patients, we know keratoconus it can be excessive eye rubbers, and it's a habit. It's not that they have allergies, but we have to try to break those habits. And I explain to patients, this is, we can do this cross-linking procedure, but if you continue to rub your eyes, you can cause your own progression. I do tell the patients that they're going to continue to see their eye care professional that they were seeing previously, and that they can, especially in the first week until things are, or week or 2 weeks till things are really healed well, they'll see me, but typically I'll refer them or send the patients back to see their optometrist to maximize their contact lens and glasses correction.
So in most communities today, it's a corneal surgeon who has the equipment, and we're often cooperatively managing these patients with other eye care providers. And it's our job to educate them as to who should we see and what are we doing. So how do you do that?
It's interesting because this has really changed the role with this team approach that we play with doctors in the community as a specialty practice. And it used to be that patients were only sent to us when they needed surgery. And now we have to completely change the mindset for other eye care providers in the community. We want to see these patients early, so we were trying to get the word out that, look, we have a new FDA-approved procedure for progressive keratoconus and ectasia after refractive surgery. So we want to see your patients when it's first diagnosed, not after you've tried multiple contact lenses and you think the patient might need a corneal transplant. And we're having more and more success at getting this covered under insurance. So it's no longer a issue financially for these patients. So we want to see these patients early, we want to get them treated, and then we want to get them back to the community doctors for the remainder of the refractive treatment. So it's changed the algorithm, if you will, that we use for community doctors and specialty practices in treating keratoconus.